So we left off talking about the AC joints. Pretty easy exam overall. They don't come in super often, but they do still come in. It's an easy comp to get should you ever see AC joints come in the hospital. That's definitely one of those ones you want to jump on because it really is quite simple overall. So how do we do this? Well, the main thing we're going to do is we're going to preferably do this x-ray standing. Preferably do it standing. We can, in emergency situations, do it lying down. But if we're lying down, we're not going to get an ideal x-ray. And the main reason for that is because when we do an AC joints series, we want to do one with weights and one without weights. Now, what's that mean? Most facilities have sandbags that you will hold in your hands. They have little loops, and you hold those actual sandbags. And holding the weights is going to open up those AC joints. They're going to open up the AC joints. So the reason we do an x-ray without weights first is because we want to see the AC joints closed. Then, on the second part of the series, we're going to do the exact same x-ray. The only difference is they're going to be holding the weights, which weights the arms down, and it's going to open up those AC joints so we get a nice, clear view of open AC joints. Very simple to do. Now, do make note this exam is done at 72-inch SID, and the reason for that is we're including both AC joints and including both clavicles. So when you think about that, it's a very wide x-ray. We're going to compensate for how wide that is by pulling that tube back and doing a 72-inch SID to make sure we include both clavicles in full and both AC joints in full because we want to see them side by side for comparison. We're going to compare the left with the right. We are going to have the patient stand with the arms in neutral. This is for the without weights, by the way. They're just going to have their arms hanging by their side, relaxed, and that's going to give us that closed AC joints view. When we have them do the same x-ray but with weights, of course, they're going to hold the weights in the hands, still having those arms in neutral, but of course, the only difference is they have weights pulling the arms down and opening up those AC joints. Now, you will see on the side there, it says without weights first. That is the preferred order that the radiologist likes the x-rays to be viewed in. So typically, you do want to go ahead and do that non-weighted version first and the weighted version second and send them in that exact order. As far as our CR, no angle. It's going to be straight at the patient, entering right at the jugular notch. Very easy landmark to palpate. You can poke that right there on your neck. That would be our jugular notch. You're going to put your crosshair directly on that jugular notch, and you'll be the exact centering point for those AC joints. As far as our breathing instructions, we are going to take this x-ray on inspiration. And this is going to be a 14 by 17 crosswise cassette. Very important to remember that, by the way, because we're doing it crosswise once again and at 72 inches because we want to include both AC joints and both clavicles. Now, you will see right there it has 10 by 12 crosswise for unilateral. I've never ever seen a doctor order a unilateral AC joint, but it does apparently exist. And if they ordered a unilateral AC joint, it's done the same way. We're just going to collimate down to one AC joint and center more so towards the clavicle. But that's a very rare thing that's ever or if done at all. I've never seen it. From what I've seen, they're always going to do that bilateral where you're right there at the jugular notch, 14 by 17 crosswise. And it does, of course, say that slit collimation, just like with the clavicles. AC joints are very thin. They're right next to our clavicles, and we don't need all that chest on the x-rays. So bring that collimation way down vertically, but leave it wide open horizontally. And of course, wall bucky's preferred, and then that gonadal shielding on the front of the patient's body. And one thing to make note of as well, when you do these two x-rays, you do want to label each. So you're going to label the first one as without weights, W/O weights, and then the second one with weights, W/weights. So make sure you label those accordingly in case you got that radiologist that doesn't know what they're looking at, which unfortunately does happen. So that would be our AP AC joints with and without weights. Now, you will see a lot of text as well, mark both sides. That's an optional and subjective choice. You don't necessarily have to put both your markers, but a lot of techs will put the right and left markers since it is a bilateral exam. So if you see them do that, it's not incorrect, but it's just a subjective choice some techs choose to do. As long as you have just the one marker, that's considered acceptable. And that's just showing you if we were going to do this supine, they would be lying down. Now, how would we achieve the weight view when we're supine? Well, obviously, we're going to do the closed view with the arms just relaxed by the side. But to achieve the weighted version lying down, which is not ideal, by the way, we'd either have someone stand in the room with the patient and pull their arms down for them, which would simulate weights, or as you see this lady here demonstrating, she has a towel around her ankles, and she's pushing her ankles on that towel while holding the both ends of it to achieve a simulated weighted view. So that's just an alternative way we can acquire those AC joints in the open position if for some reason they were just injured so bad they couldn't stand. Once again, this would not be the ideal view. We're going to prefer to do that erect with the weights, without the weights, both standing up. That would be the preferred way to do it. Now, for our evaluation criteria, we of course do want to see both those AC joints demonstrated, both closed and open, no motion, and that is a key factor for this one because, as you can imagine, if someone's holding weights, they could get very wobbly on you. So make sure you're watching them very carefully to try to achieve that X-ray with them being very still. That can be quite difficult. The optimal exposure factors and the correct markers visible. Like I said, you do want to make sure you're labeling those X-rays as with weights versus without weights. That is required on those X-rays. And we need that very close slit collimation. That way we get that nice quality AC joint X-ray showing both those clavicles and, of course, both those joints opened versus closed. Now, it can be a little difficult to see that closed versus open. I mean, if you look at both these X-rays, they're quite similar. So the main thing you're going to look for, guys, is this right here, where it says with weights versus without weights, since that is a required evaluation criteria. If you had an image like this on your test, it would be labeled with a marker. So how could I tell, Mr. Donahue? Well, it's going to say with weights and without weights. With some patients, it will be more prominent than the ones you see right here. Some of them, when you have the weights, they'll be very, very open, very easy to see. But other times, like we see right here, it's going to be a very small difference on how that joint is open versus closed. Now, I mean, one thing you can also see if you want to look at a very subtle detail, if you look at the clavicles, most of the time when a patient's holding weights, the clavicles become horizontal, almost completely horizontal, versus without weights, a patient's going to have their shoulders relaxed, so the clavicles go up at an angle. You see what I'm talking about? Without weights, they're going up at an angle. With weights, they're almost completely horizontal because that weight is pushing them down. That's a very subtle way to tell if for some reason there weren't markers on there. All right, we're going to our last body part here. We are going to talk about the scapula now. Now, the scapula itself does have some specialized views. Our routine projections are going to be our AP and lateral. And then we have just a couple of special projections we're going to go through at the very ends here. The scapula x-rays do come in quite a bit. That's another great competency to get. Now, for the AP scapula, very important that we position this correctly. We'll get to those pictures there in a second because you do see that writing there saying do not position hand like this. That is very important to not position in that manner. You know, a lot of techs will do that. So as far as the way the patient should be sitting or lying down, this can be done lying down or standing. Both are considered acceptable. Now, it's very important when we position the part here, how do we want the hand to be? You'll see it says right there for the criteria, the arm abducted 90 degrees with the hand supinated. Now, if you look at the picture on the right, does this lady have her arm at 90 degrees? No, she does not. What would be 90 degrees? You look at my screen like this, like we would for a lateral elbow, for example. Now, what do I say to you guys to help you remember this? By the way, let me show you. Hang on. Where'd my picture go? There we go. That's the way you should position for an AP scapula. I call this the stop sign. If you imagine someone at a crosswalk holding up a stop sign, they have their arm at a 90-degree angle. So you want to pretend that you're holding a stop sign, of course with the hand up, not like you're gripping the stop sign. But I call it the stop sign view. And that's a very important thing to remember because a lot of techs will do the salute. I call that doing the salute. The salute's bad. We don't want to salute anybody. If they're our military, yeah, go ahead and salute your military. But no, for x-ray, we don't want to salute anybody. We want that arm at a perfect 90-degree angle or a stop sign view. And that's important because if we don't put the arm at a 90-degree angle, the scapula will not be visualized correctly. It's going to become superimposed in the wrong way. So we must have that arm in a perfect 90-degree angle, put them in the stop sign, and leave them at the stop sign, and you'll be exactly where you need to be. Now, as far as where the CR should go, it is going to be a perpendicular beam, and you'll see it says the CR enters the mid-scapula. Now, that's not a very good landmark. I don't like that. Even though that's what your book says, I have the way that I suggest you do it, which will lead you to the mid-scapula. You remember that wonderful coracoid that I love so very much? Well, if you remember for a shoulder, we go, oh, what do you mean no? I better not see that head shaking, no. I need to see a lot of this. I've only talked about that landmark a million times. Come on now. So if you remember the coracoid, guys, we go 1 inch inferior for the shoulder x-ray. Well, for a scapula, if you position it the same way, mine is hard to find. I'm so sorry. If you position for a scapula but go 2 inches inferior to the coracoid, that's going to put you at the mid-scapular area. So to me, that's a little bit more reliable, because if you just position it mid-scapular, you're kind of just having to guess where that is. But if you go 2 inches inferior to your coracoid, that will also be the mid-scapular area. Much more reliable way to center. That's not what your book says. We need to make sure we know what the book says, but that's just an extra strategy I'm recommending that you do for those ApScapular x-rays. Now for the breathing instructions, we're going to do shallow, quiet breathing or suspended respiration. Oh, I misspelled that. Respiration. I didn't spell that right at all. I'm sorry. Respiration. Now, preferably, we want to do the shallow breathing. Why? Because the scapula will be visualized partially through the ribs. And if you remember for other x-rays we've done, when we want to blur out the ribs, what do? We do the shallow breathing. So that would be the optimized way of doing that AP. But if for some reason they're in too much pain, they're not cooperating, it is acceptable to also just suspend that respiration, but you'll get a much prettier picture if you do the shallow breathing to blur out those rib markings. Now for the cassette size, because the scapula is quite long, we are going to use a 10 by 12 lengthwise orientation, not crosswise, lengthwise. Think of the scapula being long, lengthwise. And then wall bucky versus table bucky. As most of these positions we went over, wall bucky will be preferred, erect will be preferred, but it is acceptable on the wall bucky lying down. And of course, gonadal shielding, which they did not do for this poor young man in this picture below. Make sure you put your shield on the anterior surface, covering up the gonads for proper protection purposes. But do put a big star on that, guys, because you're going to see a lot of techs out there at the clinic do their scapulas with the salute method, but we do want to do the stop sign method. That's considered ideal and optimal for an AP view. Be very careful on that. And that's what it should look like right there. We do want to see the entire scapula demonstrated with the lateral border of the scapula free of the ribs and lungs. Now that's the reason we do the stop sign, by the way. If I do not do the stop sign view, it's not going to be completely free of superposition of the ribs. That's the main reason we want that 90-degree angle. And what we're talking about is this lateral border right here. We do want that to be free of the ribs. The medial border, of course, will still be superimposed upon the ribs. This is also why we want that nice shallow breathing, because with a nice shallow breathing, we're going to blur out those rib markings and better visualize that scapula as a whole. And the centering is going to be very important to that mid-scapular area because that scapula is quite long. We do need the top of the scapula all the way down to that inferior angle and make sure we're not clipping that inferior angle on that x-ray. Lengthwise 10 by 12 cassette and proper centering and positioning to achieve all of that. So that would be our AP scapula view. AP scapula. And this tech right here did use the shallow breathing. If you notice, the ribs are quite blurry. That's showing us that they did the controlled slow breathing, blurred out the ribs, and we get a much cleaner view of that scapula where we can see both edges as well as the angles on that whole scapula. Nice, pretty triangle. All right, for a lateral scapula. Now, lateral scapula will look a little bit similar to the Y-shot x-ray. If you remember the Y-shot for the shoulder back on Wednesday, by the way, why do we do that? Why do we do the Y-shot? What's the main reason we do a Y-shot shoulder x-ray? Does anybody remember? Well, we almost been passing out on Wednesday. Why would we do a Y-shot shoulder x-ray? What are we looking for? That's a great test question. Say Say it again, Asias, you were all feedbacking.
To see the coracoid process?
Not exactly. Not exactly. There's a main reason. It involves the humerus.
Is it to view the glenoid cavity?
No, not exactly. Not exactly. Checking for something that might be out of place. Another clue for you.
To see the head of the humerus?
Okay, you're on the right track. Thank you, John, for dislocation. John just put that in the chat. We're checking for dislocation of the head of the humerus outside of the glenoid fossa or cavity. So do make a star on that, guys. That's a great test question. We do a Y-shot shoulder x-ray to check for dislocation. Now, that's important because when we look at the lateral scapula, it looks very similar to that Y-shot, but it's not done for dislocation. We're literally doing this x-ray to view the scapula in a true lateral view. And therefore, that's why it's called a lateral scapula. Primarily, we're looking at the body of the scapula. And I want you to pay attention to this as well, guys. When you go to clinic, I guarantee you most techs will do their Y-shot shoulder like you see right here with the arm crossed over. Has anybody seen that yet? Has anyone done a shoulder and seen that? Well, if you do, pay close attention because your techs will do their Y-shots like this. That is incorrect. This is the position for a lateral scapula. They're actually doing the wrong view. Now, as far as the positioning goes, it's going to be very similar to the Y-shot where we're going to put the patient in a 45-degree oblique. The main difference is, though, if you remember, for the Y-shot, we weren't really doing anything with the arm. We're just kind of having it relaxed by the side and positioning that patient into a 45-degree oblique. Scapula. It's okay. For the lateral scapula, we're actually going to have them bring the affected arm over and grab the opposite shoulder, like you see the lady doing in that picture right there. That's going to put the arm in a different position. It's going to free the humerus from the field of the scapula and allow us to visualize the scapula isolated away from the humerus. So a Y-shot lateral shoulder, the scapula will actually be superimposed upon the humerus. For a lateral scapula, the humerus is moved out of the way to isolate the scapula in a true lateral. Make sure you write that down and put a star on that because it's very easy to mix up. Very easy to mix up. Now, as far as the positioning goes, it is going to be done similar. We're going to palpate the scapula like you would for that Y-shot to try to get that true lateral. But you'll see right here on the part position, 45-degree oblique is going to be the go-to gold standard for getting that into the proper position almost every time. It does say approximately 45 degrees because much like the Y-shot, depending on the patient's anatomy, you may have to make small little adjustments to get that lateral scapula in a true lateral. But for this one in particular, 45 degrees does work more often than not. It's a lot more reliable. Now for our CR, it's still going to be a perpendicular beam. It is going to enter the mid-vertebral border of the scapula. That's the lateral border, by the way. Excuse me. And we're going to suspend the respiration and be using a 10 by 12 lengthwise still because the scapula is long. We'll include the top to the bottom on that x-ray. Wall bucky is preferred. Erect or wall bucky is preferred. And then gonadal shielding, of course. Make sure you turn it accordingly, depending on how you turn your patients. The main thing to remember there, guys, is the way that arm is positioned differently. And the Y-shot shoulder is done for dislocation. Lateral scapula is done for a true lateral scapular view with the humerus out of the way to isolate the scapula by itself. I'll show you what that looks like in just a second here. Now look at the difference here on this x-ray on the right. So a lot of people would glance at that and say, oh, that's a Y-shot. This is not a Y-shot. Even though the scapula looks like a Y, what's the key difference here? Look at the position of the humerus. This is because this patient is grabbing the alternate shoulder and they're moving that humerus out of the way. Moving the humerus out of the way isolates the scapula in a true lateral to where we can visualize it free of superposition. So this would be a lateral scapula. So pay very close attention to this. If you see an x-ray with that arm out of the way, that humerus out of the way, that's key for that being a lateral scapula. If the humerus is superimposed upon this scapula, that would be a Y-shot shoulder x-ray. Be very careful that it is so easy to mix up. So what are we looking for the evaluation criteria? We are looking for the borders of that scapula to be superimposed. That's talking about this area right here. Makes it very thin because we have superimposed the medial and lateral border. And we want that to be completely free of superimposition by those ribs. It should not be on top of the ribs. If our scapula is on top of the ribs, we did not oblique our patient enough. And we need to go ahead and make sure they're more close to a 45-degree oblique. And of course, that arm needs to be elevated out of the way so we get a nice demonstration of that full scapular body. Now, I want you guys to be careful. And the reason I'm saying this a lot, you're going to see your techs do this x-ray in place of a Y shot because they think this is a Y shot, but this is not a Y shot x-ray. This is a lateral scapula x-ray. So do not get mixed up when you see that in clinic. Of course, don't tell them they're doing it wrong because you're going to make them upset. But I just want to make sure that's very clear. They are doing that incorrectly in clinic. Because a lot of them will do it this way for Y shots. Okay, so this would be one of our specialized views right here. This is going to be a lateral scapula, specifically to visualize the acromion and the coracoid process. How it's going to put the acromion and the coracoid process in profile, much like some of the other anatomy we've talked about. So this view right here, lateral scapula for acromion and coracoid, puts the acromion and coracoid in perfect profile. Very rare x-ray, I've never seen this done. They usually just opt for a regular series. But should they be concerned with that one area, they may order this, but I've never seen it done. So this will be an erect only exam. You would not do this lying down. It must be standing. You're only going to do an anterior oblique. And we're going to center the scapula and rotate the patient 60 degrees. So much different obliquity than we're used to because most of the ones we've talked about have been what? 45 degrees. But this one in particular is going to be a very sharp oblique of 60 degrees. To put that acromion and to put that coracoid in perfect profile so we can visualize it better. As far as where the central ray goes, it's very similar. It's the same spot we would put it for a lateral scapula. We're still putting it mid-vertebral border of the scapula. In fact, it looks very similar to the positioning of the scapula when you look at it. But the main thing that's a big difference here is we're putting that patient in a very sharp oblique, 60 degrees, to isolate that coracoid and acromion and put them in true profile. For those breathing instructions, they will be suspending the respiration, and we'll still be on that 10 by 12 lengthwise cassette. You do see only Walbucky is selected. Why? Because this is Walbucky only, because they must be standing, and of course our gonadal shielding. Now, as far as where the arm rests on this exam, if you remember on the lateral scapula, they reach for the opposite shoulder to move the humerus out of the way. For this x-ray, acromion and coracoid, we're actually going to put the arm behind our back and rest it on our backside. So as if you're kind of demonstrating my camera. You see my back? Like this. You look on my camera. We're going to put the arm like this. And that's going to move that arm in the right position so we can get that nice view of the acromion and coracoid. This is where I kill for a classroom right now. So awkward. The main thing to remember on there is that very sharp anterior oblique of 60 degrees. That's going to be the main thing that's going to put those pieces of anatomy in true profile. That's what we see right down here. Here's our coracoid process in profile. Here is our acromion in profile. And we do have the scapula superimposed upon the humerus, very similar to a Y shot. The main thing is the way that this coracoid is in a true profile position and the acromion is a true profile position. That's the main two pieces of anatomy we're looking at on that x-ray. And then our final view, guys, is going to be what we call a lateral scapula in the recumbent position. Not an ideal view by any means, but should there be a traumatic situation where the patient just cannot stand and they want a lateral scapula, this is the view that we would do. So this is a lateral scapula for recumbent position. They are going to be recumbent, but they're also going to be in a posterior oblique position. Excuse me, what kind of oblique? That's going to be a 30-degree posterior oblique. So keep in mind these scapula x-rays, guys, we got 3 different kinds of obliques going on here. Watch those numbers and be careful you don't mix those up. So for this recumbent position, this lateral scapula, that's going to be a 30-degree posterior oblique. And we are going to put the arm so that it is grasping the unaffected shoulder, just like we would for a regular lateral scapula. The only difference is they're lying down on their back in an LPO or RPO position, posterior oblique, and it's only a slight oblique, which would be 30 degrees. And that's going to put that scapula in a nice true lateral. CR will be perpendicular, entering the mid-axillary border of the scapula. We're still suspending the respiration, and we are still using a 10 by 12 lengthwise cassette. Table bucky only, by the way. Table bucky only. Why? Because they can't stand. We have to do it in the table. And, of course, our gonadal shielding. So this would be reserved for our traumatic situations only. We do want to opt for the standing regular lateral scapula because that's going to be the superior view. This would be a last resort if that patient could not stand for us. So that's our lateral scapula in the recumbent position. And guess what, guys? That's the end of the chapter on the shoulder girdle. That means what? That means we're basically halfway through the semester now. Kind of amazing since we just started. We got 2 more chapters to go this semester. So I do have a test review for you guys for us to go over to give you an idea of the types of questions that may be asked. Let me get that pulled up and let's see how you do. All right. Okay, guys, if you will go to this website you see at the top of your screen, joinmyquiz.com, and enter the code that's at the top of the screen.